Hello and welcome to this video for healthcare professionals, and it's your succinct guide to COVID-19 mass vaccinations. We do hope that you find it useful and enjoy the video. Please share any thoughts in the comment section and make sure that you subscribe so that you don't miss any new content that we upload. It is now a great pleasure to introduce Mallicka Chakrabarty, who's GP partner and GP trainer from Larwood Health Partnership. Hello.
Hello. Thank you everybody for making time to come to this, what shall I say, hot from the press COVID vaccine talk. So I'm Mallicka Chakrabarty, I'm a GP and I work at Larwood Health Partnership. So those of you are wondering where on earth is this? So it's in a small ex-mining town of Worksop, which is just above East Midlands, lower end of South Yorkshire. And as I say, it's been really an interesting journey for me to even develop this talk. And thank you to many of you who've sent in the expectations and ambitions from this talk, and that has helped me formulate the talk quite a lot. I was probably having a very GP focus on this to say, how is the organization going to happen? Your suggestions and advice and ambitions have influenced me to kind of cover more on the vaccine side of things. There are a few questions around delivery. Some areas have not yet received vaccines, some areas have not started vaccines. So I'm not from NHS England. I will not vouch to answer those questions, but I will try and give you some explanation or reasons if there's any delay, what the reasons for that might be. So during the next course of 45 minutes or so, we hope to cover what are the type of COVID vaccines available. Try and understand the enhanced service, which is a specification from NHS England. Talk briefly about the standard operating procedure, but mainly signpost you to where the details can be found. Giving you an oversight of what planning involves. So if you are ever involved with it, what are the things we need to look into? And sharing with you some initial experiences. So the COVID vaccine started week commencing 7th of December, and there's been wave 1, wave 2, wave 3, and again from the 4th of January, there's been vaccinations going on, and the ones from January include both the brands of the vaccine. So there's lots of experience which is already kind of come out into common knowledge. I'm just trying to tap on the ones I've been able to get hold of and sharing that with you. So if we get started, there are lots of vaccines in the market. And even then, when we say lots, it might be 2 or 3, but it's just confusing. And human nature, we kind of try to say, oh, could I have that one? Could I have that one? And I have had my own hesitations, but I've done my research, and that's probably what has led to this talk. Before we talk about vaccines, let's talk about the problem. We all know about it. It's the life-changing thing of the century, isn't it? So a new virus called the COVID-19 or novel coronavirus originated in China. December 2019, spread rapidly to many countries, causing massive amount of mortality, morbidity, and other sort of desperate financial and economic devastation. The virus has been identified to be of the coronavirus family. It causes respiratory infections, which can range from common cold to more serious infections. The common signs, as we all know, and as a GP, when I triage my patients, I often check, have you got a high temperature? Have you got a continuous or persistent cough? And have you got a change of smell or taste? So there are many other symptoms like diarrhea, abdominal pain, chest pain, but they are in the minority. So classic symptoms tend to be temperature, persistent cough, and an altered sensation of smell and taste. Viruses differ from bacteria in that they're much smaller in size. They have a DNA or an RNA which is surrounded by a caspid, which is the protein coat on it. Viruses cannot replicate by themselves, so which means they cannot really divide by themselves. They need to actually attach onto a host cell. And once they're attached to the host cell, they manipulate the cell, and therefore they could divide and grow. In history, we have got examples of many viral diseases which have got vaccines developed. And the common one is probably influenza. And typically, we see a change in the influenza vaccine depending on what strains had happened the year before or in the preceding years. Talking about the coronavirus itself, it's a large family of viruses. It causes illness in animals and human beings, and most common illness is a respiratory illness. The range of infections can vary from common cold to more severe infections. What we talk about the SARS SARS infection from 2003, or looking at the MERS infection from 2012. And just an overview of the structure, because this is what will help us identify how the vaccine works. So what is really famous about the coronavirus is the spikes on the top, which are made of the glycoprotein. And then we have the envelope. In the envelope is what is known as hemagglutinase elastates. But the core part is the central RNA with the N protein. So when the concept of the vaccine developed, the vaccine was designed such that it prepares the immune system so that if exposed to the virus, the immune system responds to it and reduces the severity of the infection. What is striking here is it's not preventing the transmission or catching of the coronavirus, if I can use that term. So if I have the vaccine, which I will have later on today, then I am likely to still catch the coronavirus, but the expectation is my immune system will react to it and stop me from having a serious manifestation of the disease, and therefore potentially reducing mortality, morbidity, hospital admissions. In the development of the vaccines, we've had quite a few organizations and committees involved, and just to name a few, the policy was devised by the Department of Health and Social Care. The Joint Committee on Vaccinations and Immunization came up with the criteria to say, is this vaccine safe? Is this effective? And why is there a need for the program? And finally, in terms of the product review, that was done by MHRA, which is responsible as an independent organization for the oversight of the vaccine manufacture. It's been a long journey thinking about the smallpox vaccine and the technology that's being used today, the mRNA technology, for manufacturing some of the vaccines for coronavirus. So in terms of the development of coronavirus vaccine, it has been slightly different to any vaccines we might have heard about. There's a lot of work right from the start of the pandemic about collaborative working among the scientists. The same amount of progress would have actually honestly taken months, but here a lot of work was done in a very safe and effective way, and sometimes even parallelly. Clinical trials were obviously done quite rapidly, and we can say the same thing about approval by the ethics committee or any other formalities that the vaccines needed to go through. But most importantly, loss of work, which normally in the development of vaccine happens sequentially, here it was happening more parallelly, and that's where the major time saving is. And in honest reality, like every other vaccine, we are now in stage 4. So as this vaccine is being rolled out, we are observing the licensing and what's happening, what are the after effects as it is being used, or what are the effects after it's being used. So what is the principle behind it? So by knowing the genetic code of the SARS coronavirus 2, various methods are being used to create the vaccine. And probably a popular one is the mRNA itself, or the other method is using the genetic code into an existing virus, attenuating the virus, and then using the virus as a vector. So we'll talk about the Pfizer vaccine. It is commonly known as the Pfizer vaccine, but it's obviously got a scientific name to it, which is the BNT162b2. This is the first vaccine which was launched and was also made available in the UK. Now this uses mRNA, which is the messenger RNA. What happens is it contains the genetic sequence from the spike protein found on the surface of the SARS-2 coronavirus. that is wrapped up in the protein envelope, also called as the nanoparticle. When the vaccine is injected into an individual, the mRNA is taken up by the host cells, which then translates the genetic information and produces the spike proteins. These are then displayed on the surface of the cell. That's now going to stimulate the immune system of the body to activate the T cells and to prepare the immune system to fight the infection and disable any viral infections. There is no live virus, there is no whole virus, so the vaccine itself does not cause the disease. The mRNA injected degrades in a few days' time. The second vaccine made available to the market was the AstraZeneca COVID-19 vaccine, developed in Oxford, or commonly also referred as the Oxford vaccine. Now, the AstraZeneca vaccine is slightly different technology. They've used the viral vector for the vaccine, which is a weakened adenovirus, which carries the SARS-CoV-2 antigen virus, COVID antigen into the body. So the adenovirus has been modified such that it will replicate in the human cells, but it will not cause any disease. The genes will then code for the proteins on the surface of the SARS-CoV virus, and that's been inserted into the adenovirus genetic code to make the vaccine. Once injected, the host cells will then manufacture the spike proteins. This will stimulate the immune system, which reacts by producing antibodies, memory cells, to the COVID-19 virus without actually causing the disease. The Joint Committee of Vaccinations and Immunizations came up with what was called as the priority groups for the vaccinations. And top of the list we know is the most vulnerable, so residents at care homes and nursing homes. Those next most vulnerable were considered anybody over the age of 80 and frontline healthcare and social care professionals. And thereafter, it's very much including the population, depending on the age, 75, 70, 60, 65, 60, and it goes down up to the age of 50. In between are considered vulnerable are those people with significant health conditions. So what really strikes about this group or division is there's no mention of including anybody under the age of 50, definitely, but no mention of including any children. And there is also no inclusion of pregnant women. And the clinical risk groups we are already familiar with, say from the flu vaccines, so long-term respiratory conditions, long-term heart conditions, kidney disease, liver disease, neurological diseases, diabetes, any medications, any conditions which will reduce the immune system, asplenia, morbid obesity, severe mental illness. But the new category included was anybody who was considered suitable for shielding either by the GP or by a hospital consultant is also considered to fall in the clinical risk groups. Just a word about pregnancy and breastfeeding and how this is kind of evolving. So as regards to the Joint Committee of Vaccines and Immunizations thinking or advice with regards to both the vaccines, so that's the Pfizer vaccine and the AstraZeneca vaccine, it can be offered to pregnant women or women who are breastfeeding. What they say is there's not enough known about the risks which are associated with giving these non-live vaccines during pregnancy. They're not known to have caused infection in women or unborn children, although data is not definitely indicative of any safety concerns, but there's no evidence of any harm. And currently, there's insufficient evidence to recommend a routine use of COVID-19 vaccine during pregnancy. If, however, it is considered that there is a suitable lady whose risk of infections are quite high, or the risk of developing complications are quite high, then having an informed discussion with them about the risks and benefits of the vaccine, and obviously telling them that in the absence of any safety data of the vaccine in pregnancy, and should they be willing to receive it, then that's absolutely fine. Again, the same pretty much applies to breastfeeding. So there is no known risks which is associated to giving non-live vaccines whilst breastfeeding. But the same safety concerns and declarations and giving them the pros and the cons apply. What are the other vaccines which are available? So Moderna is the one which is probably next up for licensing. It's finished the phase 3 trials. And there are a few other vaccines, which is the Novavax, Valneva. There is one from GSK and Sanofi Pasteur and one from Janssen. And they are in different stages of clinical trials. In terms of the UK has secured 357 million of different vaccines of the ones mentioned. So that includes Pfizer, AstraZeneca, plus the one mentioned, in the hope of vaccinating the entire population as far as possible. And so now moving on to what was the DES or the enhanced service with relation to the COVID-19 vaccination program. So BMA and NHS England came up with the enhanced service for this program, which we shall be referring to hence as the coronavirus vaccination program. And this was mainly directed for the general practice in England to lead the delivery of the vaccination program. The idea was this will be delivered in groups, pretty much following the primary care network footprints. And the first wave commenced week commencing 14th of December, although in the hospitals, the rollout in the hospital hubs were week commencing 7th of December. So in December, there were 3 weeks of vaccinations, but most vaccinations are expected to take place, and they've already started week commencing 4th of January. And this has allowed practices to, in some way, be more prepared and be more geared up for this. So what is the approach? The approach that is adopted is giving the high priority groups the vaccination as it becomes available. And gradually, as different vaccines become available, we increase the number of residents, patients who can have the vaccinations. Vaccinations can be considered for housebound patients at home visits and also care home residents, but also to staff of the care homes as well. There's obviously, it's absolutely implied that the community services will also play a role in this, particularly the housebound patients who may do the same thing like they would help with the flu vaccinations with the practices. The practices are able to vaccinate their own staff. So I'm having my vaccines at my own practice where I'm registered somewhere else. There is plans for this to be rolled out for the local pharmacies when the general practice cover is not enough. And there will be national and local public campaigns which will advertise the services on offer and what patients are eligible for. So if we look at the enhanced service specification, it's quite a vast document. And if I break it down into what does it mean in terms of PCN, what does it mean in terms of workload, what have we got to do with the vaccines, it's probably easier. So for the PCN, what was the main thing? It was having one site of delivery. So the practices might be based over between 5, 13, 50 sites, but having probably one site, maybe 2 sites if many practices were involved as a site of delivery. Collaborating with community providers, planning for a start in early December. Prioritizing clinical workload. So as a GP, we've had to stop many routine works, like probably the gynae procedures, minor operations, just to free up capacity and make GPs and nursing staff available for this vaccination program. Extended hours or extended access, as it is called in different parts of the country. Those hours were all now focused on delivering the vaccine, because this has to be a 12-hour 8 to 8 service if we have to deliver the expected number of vaccines, which is not just a delivery requirement, but is also a requirement in terms of minimizing wastage. Thinking about patient cohorts. So we've looked at the risk groups, but the idea is anybody above the age of 50 will be vaccinated. Care home residents, those who are homebound, will be vaccinated. Care home staff, primary care staff will be vaccinated. And also there is a separate commissioning policy being considered for the homeless or any other vulnerable members of the society. In terms of how this will be actually delivered, how this will happen, there is a national recall along with a local recall. There can be a practice recall, call and recall system as well. For those lacking capacity, ideally consent should be obtained the day before, but consenting just before they attend for the procedure is fine for others. Booking systems can be national or local. 15 minutes observation time for vaccine on observation. And this has undergone a massive change. Sometimes it was said yes, then it was said no to driving, and then it was said no, yes, we have to observe. And now it is mandatory to have a GP on site the premises where the vaccination is being conducted, and also a 15-minute observation time for each subject who is vaccinated. There is a massive collaboration involved here about agreement, staff sharing, vaccine sharing, and everything else. Now, 2 doses must be provided by the same provider. So the idea is, if I'm being vaccinated by practice X, they will also vaccinate me for the second dose. If for some reason they are not able to, that should be suitably communicated with relevant evidence. The patient can choose where to attend. Now, that is probably a bit limited now when a few practices are, a few PCNs are able to organize it. But once mass vaccinations are available, the patients will have a choice to go to the mass vaccination center or go to their own practice PCN, or maybe a pharmacist. In terms of indemnity, so this can be indemnity for the staff, this can be indemnity for the admin staff, this can be indemnity for the marshals volunteering, everything is covered by the CNSGP indemnity cover. There are SOPs written up by NHS England, a link to which is there in future slides. When documenting, they will document the vaccine type, the batch number, the dose, the person who was drawing it, the person who was administering it, date and the time of vaccine, where it was administered, and if there were any adverse reactions during the observed 15 minutes. This reporting is to be confirmed. In terms of workforce, so all staff need to have the public health e-learning completed. This is available through the e-learning for health. Keeping track of all the paper records. So this is not just the COVID vaccine, but also making sure that all of the staff involved with the vaccination are up to date with their BLS, are up to date with their anaphylaxis management. And also when it involves PGD, getting all the documentation sorted and having the vaccine progress overview pack organized. So these paperwork is massive and needs to be done before the program is started. Workforce can be the practice PCN's own workforce, but there is a massive contribution from the voluntary sectors. You might have heard about St. John's recruiting volunteers. There is an advertisement open for volunteers on the NHS England website. We can use wider staff, but they are all need to be engaged or employed in some form with the organization. BMA has drawn up honorary contract, and I'm told the staff who are involved with marshalling have got a confidential contract again with the practice and the PCN. Using local relationships, so like our local voluntary services are all contributing with the marshalling and and also organizing the queues, the car parks of these vaccines. Finances. So each practice PCN delivering this gets about £12.58 per vaccine, which roughly amounts to £25 per vaccine. Usually the payment is made after 2 vaccines are delivered. Sometimes it is possible the patient was just had 1 vaccine and did not have the second dose. In those cases, payment is available for just the one-off. There is some more what is called as a non-recurrent funding, which is to allow for the other expenses, which can be staff or premises, IT, or anything else. In terms of the site, careful planning, coordination, safety and security of the premises. Minimizing wastage, waste collections. The wastage of the vaccines is said to be kept at a minimum, try and keep it less than 5%, and also how the clinical waste will be collected. The idea is it'll be delivered over 7 days. So don't think it happened over Christmas, but it's happening this weekend for our practice. It will be an 8 to 8 service, so start at 8 o'clock in the morning and run up to 8 in the evening, and it can extend over back holidays or weekends. Now, this obviously specifically applied to the Pfizer vaccine because that was the first one to be rolled out. They come in a batch of 975s, and the idea was you have to use the 975 vaccines over 7 days. Now, what that means is effectively in 5 days, because working week of 5 days. The transport time is 1.5 days. So effectively using 975 vaccines in 3.5 days, making sure the appointments are booked corresponding to when the vaccines are delivered. Using external hours, external access, all those hours into delivering the vaccines. So really quite a lot of GP appointments are cut down, and demonstrating equality impact for all clinic plans. In terms of the vaccine supply, it is a central supply. It's coming in batches of 975, especially as I said, for the Pfizer vaccine. There is a specific ordering system, although I am told now it is very much a push system, which means they deliver it to you. We can't ask for it. The plan initially was the 2 doses are to be delivered, with the second dose being delivered between 21 and 28 days. This seems to have changed, and this has changed only over the new year, where the idea was to vaccinate more people, you need probably more first dose to be administered, and you are protecting large number of population rather than actually vaccinating the selective few and kind of repeating that cycle. So yes, debatable, and also variability in how it's been conducted. But practices had appointments booked on the 4th of January, and I know parts of the country where they have delivered the second vaccine as well. So there is a bit of a variance there, but the idea is first dose for the Pfizer vaccine gives a protection between 70 and 90%. That protection starts 2 to 3 weeks after the vaccine and should hopefully carry on. And by between 6 and 12 weeks, the second vaccine should be organized. The vaccine needs drawing up, needs reconstituting. The storage is very specific, which is why we're talking about the shelf life of 5 days and delivery within 3.5 days when it comes to administration. And the national PGD. It doesn't really get any easier because the vaccines have to be delivered in socially distanced environment and still performing the 15 minutes observation post-vaccines. There are specific guidelines about administering COVID vaccines and flu vaccines separately. So for COVID vaccines and flu vaccines, minimum of 7 days gap. Similarly, if somebody has had COVID, they have to wait 4 weeks before they actually get the vaccines. Thinking about all the consumables, syringe, diluent, administration, needles, PPE, everything else that goes with administering the vaccine. So the standard operating procedure, which was produced by NHS England, was actually contracted to provide local vaccination service in a community setting, including NHS sites, which is practices, community pharmacy, non-NHS site, care homes, patient's own home. And all NHS and non-NHS sites providing vaccines have their own designated, which is commissioner-led assessment process to see if the facilities were appropriate and also if it was suitable to start the vaccination program. As I say, this is a massive, about 54-page document, and if the slides will be made available to you, so should you look up or want to look up more, this is the link to look up the document and see specific sections of how detailed the guidelines is. What I have not covered in the original section was the provision for the anaphylaxis, because that was not included in the enhanced services. But it has been updated in the SOP, which has only been updated on the 6th of January actually, is within the premises where the vaccine's been developed, each of the vaccinators should have an easy access to all the medications and anaphylaxis equipment. how do we ensure that your team is prepared, or what do you actually need? So I've tried to summarize it in one slide, but I don't think it does it justice, because this is an extensive amount of work. And my colleagues and friends who are clinical directors of PCN tell me how exhaustive it has been. So organizing your team, whether it is clinical and non-clinical. Your clinical team might include clinical pharmacists, paramedics, healthcare support workers, practice nurses, nurse practitioners, GPs. Non-clinical, the admin team to do the recall, the booking, people volunteering to manage queues, manage parking spaces, support the less bodied resident subjects who are coming in for vaccine. Ensuring access to the site, so a wide entrance, having a queuing system, or which is also possible to be continued following the social distancing measures. Security, space, how far is it from the practices? So how will the patients be able to come there? Car park. So my friend who runs a GP practice in Newcastle was saying me, her patients were not able to come for the vaccines at 8 in the morning because the bus pass is valid from 9:30. And the CCG had to liaise with the council, and for the days of the vaccination, the bus pass had to be valid from 8 to 8. So there is an immense amount of work specific to each site, each organization that will need to work. And absolutely essential is the involvement of voluntary sector. Without their help, the marshalling, controlling the queue, crowd management wouldn't have been possible. So what is the initial idea? What is emerging out of the first wave of the COVID vaccine? What experience do we have? So I must say it's generally positive. The challenges are with the supply of the vaccines and the changing guidelines, but these are challenges that we kind of have to live with in the uncertain circumstances. It is a massive amount of hard work, right from tracking the vaccine to making sure that they're delivered with minimum wastage. It's long days, so the 3.5 days are all 12-hour days, 12 hours as far as possible, and it's massive team working involved. You know, I can see our clinical pharmacists, our nurse practitioners, the healthcare, everybody there involved in delivering the vaccines and making sure that actually the organization and it's perfectly running. And what I can also see is a massive sense of pride in those who have done the vaccinations. So there is a recently qualified nurse who comes in to do the vaccine, and she feels like she has done her bit for public health by participating in this program. And that's really a valuable sense of achievement. For those not involved actively in the vaccine program, there is an immense sense for controlling the clinical front and to be able to release colleagues who have gone out and delivered the vaccine. So overall, I see a very high a positivity, a sense of achievement, pride. And if I have to quantify that and see what learning, was there anything that we could have done differently? So most places run between 4 and 5 lines, and it was very quickly recognized that some lines might move slowly, there can be delays. So it's best to kind of recognize that there are some slow running lines and there are some steady lines. And if you have to move patients to make the lines run smoothly, that's absolutely fine. Those lines which are running slowly, you need more admin support. And that's often been the elderly who have had months of shielding. They have come out. This is probably the first time they've left their house to confidently come out and have a vaccine. And they have got their stories to tell. So it's just kind of, there are other things which are very human, which have slowed the process, but it's important to acknowledge. Different places, different lines have operated differently. Where there's been a band 5 and above, they have done the drawing up and the administration, whereas in some places, we might have had a clinical pharmacist drawing up the vaccine, another person administering, and the documentation is done by a third person. And each of these have shown to have kind of different efficacies, different time. Generally, between 5 and 6 minutes, most vaccine delivery and documentation can be done. It's really surprising, very low DNAs and absolutely minimum wastage. And that's really impressive. And the delivery times and booking, so most deliveries tend to happen in the morning. So the ideal time to possibly book is late afternoon. So where we have seen bookings done from midday, they've had to have a delayed start to the clinic or cancellations. So it's not just the vaccine delivery, it's also the equipment delivery that we have to bear in mind when we are planning. So maybe a 4 or 5 o'clock start date for the first day before the long days is a good option. Having the provision of extra masks, it's always, somebody would have forgotten it. So having those spare masks at the entrance, just in case people need it. Staggering lines, as you see the line, there's a bit of a build-up. Patients who need support, relatives who need to support patients. There were marshals who were going up to the car park and bringing the patients there. And so again, you're minimizing the number of people who we can come in contact with. And pre-check if it can be done, especially in terms of allergies, consents, leaflets, where this has been done beforehand. So when I say beforehand, either the day before or where it's possible, as they are queuing up for the vaccine, that has known to save time. And more staff's required at the front end, so managing queues, managing car parks, having dedicated car parks. It's seen that if the more staff is actually, the more staff you have there, the better is the service delivery. With the introduction of the Oxford vaccine comes the transportation to the care homes. And there are again considerations to be made about making sure that everything is well coordinated. With regards to care home delivery and especially patients lacking capacity, the discussion about the consenting 1 day before. So each vial of the Pfizer vaccine, it was said we could safely administer 5 doses, 6 doses was like, if you can do it, that's fine. But now there is an immense pressure to try and be as accurate as possible and to extract a 6th accurate dose, if possible, from the vials, again, to minimize wastage. So that is, in short, kind of an overview of what's already happened. But the bigger picture is yet to emerge. So there are going to be what is known as mass vaccinations. These will be much bigger sites. You might have heard about Morrison's volunteering its car park for these vaccination sites. And you will see massive community participation, like St. John's recruiting volunteers, and the NHS website asking for volunteers. So this will have a more of a national or regional call-up systems and booking systems. But the bigger picture, as more vaccines become available, is yet to emerge. And there is a lot to be learned from the whole process still. So thank you all for your patient listening. Time for any questions if you have any.
Thanks, Mallicka, that was brilliant. We've got lots of questions that have come through, so I will get started. I do think that you might have answered some of them already, but I'll read through them, and then if you've got anything additional to add, then we can do it that way.
Sure, thank you.
So the first question is, what is your opinion on the proposed change of the dosing schedule for the vaccine? I believe that MHRA has approved second doses being delivered after the initially agreed 3 weeks time window, but I've also heard that Pfizer has said that they couldn't condone that, that they didn't have the clinical trial data to support it. I was confused about this conflict and would appreciate some clarification.
Absolutely. So I think we were all confused on New Year's Day when we heard this. But looking at evidence, the protection from the first dose is 70 to 90%. And the idea of vaccinating more people rather than specific groups seems much more appealing. Yes, the volumes to be vaccinated and the time duration are still unrealistic, but it possibly makes more sense to actually have one vaccine than to and try and kind of distribute one vaccine more to a larger part of the population. Yes, there are challenges. The WHO is still to agree to this. And different things are happening in different parts of the country. The second vaccines booked for the 4th of January have happened. So there are some people who have had the second dose. But the reality is probably one dose and then having the next dose between 6 and 12 weeks. And that's what's going to happen and seems perfectly safe.
Okay, that's brilliant. Thank you. Have been asked whether any of them affect fertility?
So I have not looked up anything, but when I was looking up the vaccine efficacy and safety in pregnancy, they have gone on to say if a woman has had the vaccine and discovers she is pregnant, there is no need to consider termination, and they can still safely go ahead with the pregnancy. But I haven't still come across anything to say it affects fertility. But looking at the mechanism of action, I do not see why it should affect fertility.
Okay, brilliant. I can see lots of people asking questions in the chat box.
Yeah.
I'm really focusing on asking the questions that have been written in the Q&A box. So if everybody that's got questions can put them in the Q&A box, it's just a bit easier for me to follow that way if they're all in one place. So the next question is, if a person has a pre-existing respiratory condition, would they necessarily get serious form of COVID should they catch it?
So most of the damage caused from coronavirus or COVID-19 is an inflammatory response. And it's difficult to say who responds how, but if they have a compromised pulmonary capacity to start with, then the more debris, the more fluid accumulating in the lung, the harder it is for the breathing. So probably, precautionary, it is best avoided.
Okay, brilliant, thank you. This is another question about the Pfizer vaccine and the conflicting opinions coming through from the WHO and UK medical advisors, which I think we've already covered, and also just the latest on pregnancy and breastfeeding, which I believe you've covered as well.
Sure.
If a patient has exacerbations of COPD, how long after taking antibiotics and steroids should they wait to have the vaccine? Should they wait longer after having taken steroids?
So steroids would increase the shedding of the coronavirus. I'm not aware of any specific duration. Looking at people who have had coronavirus and having the vaccine, the specified duration is 4 weeks. So I would possibly say anything between a speedy recovery and 4 weeks seems to be a reasonable length of time by which they can have the vaccines.
Okay, fantastic. Do NHS staff continue with lateral flow testing once they've received the first dose of the vaccine?
So yes, because we talked about the vaccine actually stopping the immune response to the virus, but it doesn't stop you contracting the virus. So the lateral flow test, which is to identify carriers, should still be able to be continued.
Okay. And I guess that's the same for those that have completed both doses as well.
Absolutely.
Okay. Is it possible that we've answered that one, completely vaccinated staff can still be carriers of the virus?
Absolutely, yeah.
Thank you. Now that we have got ahead with this, will the AstraZeneca vaccine practices, sorry, it's worded quite slightly funny. How much local flexibility will there be with the practices of the AstraZeneca virus?
So as I was talking about the supply of the vaccine, this is working on what is called as the push system. So it's entirely what the regional coordinator center is sending to the PCNs or the practices. So both the vaccines are available to PCNs practice delivery centers, but number of each depends. Sometimes it's been 975, sometimes it's been 75. What I would be able to tell you is the AstraZeneca vaccine is purely been reserved for people who are homebound or care home residents just because of the transportation, and also people who have got a severe anaphylactic reaction and carry an EpiPen.
Okay, brilliant. So that would be the kind of alternative vaccine for those with...
Absolutely, yeah.
Brilliant, thank you. Can you clarify the difference between vaccine population level and individual protection following the vaccination?
So individual protection is between 70 and 90% after the first dose of the Pfizer vaccine and close to 99% after the second dose of the vaccine. What we do not know is how long the immunity lasts. And there are currently no talks about whether there will be another test, whether they'll need a booster. The AstraZeneca vaccine or the Oxford vaccine is slightly lower at about 90% for individual vaccination efficacy. And the Moderna is coming up with slightly higher long-term protection rate. So there is a claim that it could be effective for as long as 2 years, which is not a claim that the other two vaccines are making. I possibly do not have any data to talk about the population level efficacy.
Thank you. Which vaccine is best for someone who is on medication making them immunosuppressed?
So sadly, we do not have a choice, and the only governing criteria is, are they homebound? Can they travel? If they can travel and they have not had an anaphylactic reaction, there's no reason why they cannot have the Pfizer vaccine.
Okay, thank you. What measures are in place to reduce the incidence of human error in recording vaccination data?
So there is a pre-booking, so there is a specific number of bookings done already. So there is a check at the point of entry. There's a check at the point of administration and delivery. And post-procedure, there is a data collation. So there are 4 levels at which this is being checked. Our practice, having run it once in December and one during this week, I've not been aware of any situations either in my practice or in adjacent practices where there have been any misdocumentation.
Okay, thank you. Are there any plans to vaccinate family members of those who have relatives in care facilities?
So no. But again, some practices, especially around Doncaster area, I'm aware, to minimize wastage, decided to vaccinate the spouses of all members of practice staff. And that's probably a good idea rather than actually waste. It didn't fit any of the guidelines, but I know it's happened.
Brilliant. Once we are fully vaccinated, will shielded staff be able to return to work?
That is like, how long is a piece of string? And I think, don't know. And I say this with hesitation because of the new strain of the virus. And I'm surprised there's no question on that. So we don't know the efficacy of the new strain of the virus and the vaccines. The companies have claimed that the mutations are affecting only 1% of the protein in the virus. So 99% the virus is same. Having said that, the studies to see the efficacy are not quite available. So we do not know is the honest answer.
Okay, thank you. Has pork or similar been used in any of the vaccines? If so, do you think there could be religious opposition to on some grounds regarding the possible pork mediums used in the creation of the vaccine?
So when I've looked through the advice leaflet, which is obviously from the public health, there is no mention of anything like this, which is why there is no, I wouldn't probably say this is not a specific concern. And considering the fact that people of South Asian ethnicity are at higher risk of infections, I'm sure this would have been highlighted, especially if this was a concern.
Okay, brilliant, thank you. So I have received the first dose on the 15th of December and the second one, initially scheduled for the 7th of January, has been postponed. Mm-hmm. Changing my NHS employer on the 25th of January, is there a process to ensure continuity and completion of immunisation within the 12-week timeframe?
So tricky, but possible. So it all depends on where was the first place of your vaccination. Was it through your previous employer? And arranging a suitable recall with them, which I'm sure will be all possible and done. There is equally an arrangement possible from the practice PCN side that they have delivered the first vaccine and the responsibility for the second vaccine could then be delegated to you to say if you want to have it with your second employer or second provider. We have got staff in this position. I myself look after a rehab home where patients are resident for not more than 3 to 6 weeks. but they're all been vaccinated. So we are not using this potential change of place as a reason not to vaccinate people.
Okay, that's really helpful, thank you. So you mentioned that you need 15 minutes for post-observation after the vaccine. Someone's asked, how long do you allow for your appointments?
5 minutes at the minute.
Thank you. Are there contradictions for people on immunosuppression medication and warfarin?
Now, the only contraindication is really severe anaphylactic reaction and the need for carrying EpiPen.
Thank you. We've answered this one on the current vaccine being effective on new strains, so that's great. If a person has been PCR COVID-19 positive, can they still have the vaccine regardless of time lapse?
So yes, if they've had a COVID positive test, they can have the COVID vaccine, and it is after 4 weeks.
Okay, thank you. Is there a strategy for vaccine refusal NHS staff?
I'm not sure there's a policy. So I myself refused the vaccine when it was first administered because I just didn't think I had enough information to make the decision. But also it was one of those urgent calls saying, would you like your vaccine? Can you come here in the next half an hour? And I just thought, well, I'm not quite ready. I wasn't really expecting this call, so I had to say no. But there is a lot of emails which are persuading staff to encourage them to take it. But at the end of the day, if somebody has capacity and that is their decision, it has to be respected.
Thank you. Does supervision have to be done by a nurse? Could it be done by a paramedic or other registrant if they are available?
Yes, anybody can do the supervision, but a GP has to be present in the premises where the vaccination is being conducted.
Okay, thank you. How will the risk of anaphylaxis be assessed in a PCN setting where the patients may come from a different practice?
Sure. So once we talked about when they're working together, there is a lot of agreement about sharing, and one of the things is sharing information, and the person booking the subjects or the residents into the clinic, vaccine clinics, will have access to the medical history, but they'll also be asked a specific question. So there is a questionnaire at the time of booking saying, have you had COVID? Have you got any symptoms now? And also includes, are you allergic to anything? Do you carry an EpiPen? Have you had a severe anaphylactic reaction? So there is a pre-check questionnaire, and that is again repeated just at the entrance of the building where these are being conducted. It can be done in different ways. Some places it's been done as the vaccine is being prepared and drawn up, but there are at least 2 checks being done on the history.
Okay, thank you. How long do you need to defer the second dose of the vaccine if a COVID positive result recently?
Yeah, so it's about 4 weeks. So from having the infection, the recommended duration is 4 weeks before they can have the vaccine.
Thank you. How can hospital consultants and doctors actively support the vaccination program as a vaccinator?
Actively support. So if obviously you have the time and the capacity to participate in the vaccination program yourselves, and I'm sure each trust would look into including any clinicians that are able to participate. The other option would obviously be available to be there as a clinician who is having all the resuscitation facilities, so we have access to all emergency support during the vaccination cover. But that is just the minimum. That is obviously use of the right clinical skills, but there is nothing that stops you from marshalling volunteering in general.
Brilliant, thank you. Does the NHS SOP require patients to have had a negative COVID test days before they've had their vaccination?
No, not at all.
No. And if someone did happen to be an asymptomatic COVID carrier and subsequently had the vaccination, would they react any differently to someone?
So this is not something that has emerged from the clinical data, from the clinical trial data. And if you think about it, even after having the vaccine, there can be asymptomatic carriers. So it does not make any difference to the process.
Okay, brilliant. Can you guide us on long-term safety data for these vaccines? We've had some questions asked about long-term safety regarding the vaccines and some reference to
thalidomide.
Yes, thank you. And unknown consequences. Thank you.
So as I said, the phase 4 is on now. So phase 4 trial. So this is what's been, what is actually happening in real life, and everything been recorded. So on the day 2 of the vaccines were rolled out 8th of December in Coventry, and then on the day 2 of vaccines, there was severe anaphylaxis reported. Obviously, it is too early to report any long-term data from the vaccine itself, but it's possibly even too early to report any long-term data from the clinical trials. But so far from the trials, there's nothing been reported, and nothing adverse been reported to suggest that there's any long-term adverse effect.
Okay, brilliant, thank you. So there's a couple of questions about housebound patients. Do the vaccines come from their registered practice, and how will they be delivered? And how does the observation time work for housebound patients?
Sure. So if I answer the second part of the question first, so the observation time mainly relates to the Pfizer vaccine, because that has been reported to have more anaphylactic reactions. And subjects who have had anaphylactic reactions or carrier EpiPen can have the AstraZeneca vaccine. So in a care home, residential home, or homebound situation, there's a healthcare professional, which can either be a practice nurse, a district nurse, or a community matron nurse practitioner who would go out, or even a paramedic, clinical pharmacist who have gone out and done the vaccine. They don't leave the premises after doing the vaccines. They are still there. So effectively, they have vaccinated one person and they're moving on to the other person. That complete the documentation in the same room as far as possible, change PPE. And my understanding is this has allowed them some time between each vaccines, but there is no need to observe residents for 15 minutes as it is being done for the Pfizer vaccine.
Okay, brilliant, thank you. Like the flu vaccine, this vaccine may possibly be annual. As described in the presentation, it does not protect individual from getting COVID, but minimize effects.
Yeah, absolutely. So we were talking about, we don't quite know how long the immunity would last, and Moderna vaccines have a claim that it is lasting for up to 2 years. So we might see quite a few regulations, and I do anticipate long-haul flights will have a requirement of carrying a COVID vaccine certificate. And similarly, once we know about how long the immunity lasts, we might see the needs for boosters.
Okay, that's great, thank you. We've still got a lot of questions and only a couple of minutes left, so I will answer 2 or 3 more and then we will have to leave it there, unfortunately. Earlier you mentioned that GPs have to be present where COVID vaccines are being administered. How would this work when administering in patients' homes? We've answered that one, I believe.
Yeah.
Are patients given an option on which vaccine they would prefer to have?
Sadly not, but I don't think that day is far off when the pharmacies administer it, and the vaccines, the supply-demand gap is slightly less. It might be possible.
Okay, thank you. How do you ensure your organisation is on the vaccination list?
So the process started early on in November, and there are lots of criteria, well, at least 2 criteria that I can think of. So because it started with the most vulnerable, which is care home residents and above 80s. And those were the main criteria which decided which practices or PCN could work collaboratively on this. So I know of a colleague or friend who works in Milton Keynes, and her practice, the number of above 80s is only 120, and they did not qualify for wave 1. And the chances are they will have a trust-led vaccination where their above 80s will be able to go in. Whereas in our PCN, the number of above 80s were 1,200. 600 of whom were mobile, which meant that we had a chunk of population who could come and have the vaccine and use more than 50% of the 975 vaccine delivery. The second step is the arrangements. So the sites had to be confirmed by the 17th of November, but also the security of the site. So the vaccines would be stored there, alarms, computer systems, manpower, geared up, plan how it will be administered. These have to be presented to the ICS or to the CCG, and they look at how robust the plan is. There have been practice PCNs which have been stood down because their plans were not considered robust, and they will probably figure in the subsequent waves. But yes, there are some criteria to see what actually makes a PCN or practice eligible to have the vaccine, to go ahead with the vaccine.
Okay, thank you. Is there a central database like the child health information system being used or developed?
So there is an idea of a national recall, which will probably be much more up and running with the mass vaccinations. At the moment, it is all very practice-led or PCN-led as far as I know.
Thank you. In our area, we've had a high DNA rate for the second vaccine appointment. Have you got any advice for what you're going to do about it? It's particularly with staff members. And do you offer further appointments?
Understanding the consequences. So I was talking about my friend in Newcastle who actually had quite a few DNAs on the first day of the vaccine. And she rang the patients to say, you know, we've offered you the vaccine, what's the matter? And they said silly things like, oh, I need somebody to take me there, and I've got, my son works so and so hours and I can't have people, I can't travel any other time, or the bus pass is valid only after 9:30. And they have had to then go back to the CCG and make collaborative arrangements with the council where the bus pass extension was valid for extended hours. And in fact, they've also provided transport where a normal transport would carry probably 6 patients, but they have carried, say, 4 patients to a vaccination site and again return them back home. So there have been quite a few places who have worked innovatively to try and support the uptake of the vaccines.
That's great. And do you have the link for any e-learning?
That's absolutely fine. I should be able to attach it in one of the sites and send it. It is a free e-learning. It is e-learning for health. As a GP, I know it requires my GMC number as my username, but I'm sure there should be another option because our clinical nurse practitioners have also done the course, and I can definitely include that.
Okay, that's brilliant. That is all that we've got time for today. I know that we have got lots of questions coming through still, but hopefully we've answered as many as we can, and you've all got the answers that you're looking for. Thank you so much, Mallicka, for taking some time out today and sharing your wealth of knowledge and answering all of those questions. You've been brilliant, so thank you.
Lovely, it's a pleasure. Thank you.
Thank you.